Now we will move to the panel discussion. My colleague Mabruk Al Tamer Ashraf and me will be the moderator of this panel. Dr. Sameh Shahata will take some question to pass it as a moderator, and will also comment on these questions. So let me start. Dear panelists, colleagues, and friends, I would like to welcome you all to this panel discussion. It's my greatest pleasure to have you all on board. Special thanks to our standing panelists who have endless experience in our topics. Tonight, we have, besides our speakers, Professor Sameh Shahata, the current president of the WOFAPS and the past president of EPSA. Professor Sharif Shahata, the current president of EPSA. Professor Ahmed Durram, professor of pediatric surgery at Al-Azhar University, and Professor Aminim Shams, professor of pediatric surgery in Al-Azhar University. First, I would like to express our gratitude to Professor Sulaiman, Professor Mabruk, Professor Tamer, and Dr. Mohammed Magid for their effort in organizing this webinar. The topic to be covered in this panel is non-surgical treatment of primary hyperhidrosis, advances and different technique of sympathetic thoracoscopic sympathectomy, the post-thoracoscopic sympathectomy complication, and redo operation for recurrence. Currently, primary hyperhidrosis is the main indication for thoracoscopic sympathectomy in children. Actually, Fabio and Juan covered all about the non-surgical treatment. Just a reminder, we have topical therapy, iontophoresis, botulinum toxin, and oral treatment. So the first question is, do you have experience with botulinum toxin? And I will pass this question to Professor Juan. Professor Juan, please. Professor Juan.
Activate my mic. Yes.
Yes.
No, I don't have personally experience on that, because we have our patients are taken to the dermatologist of our hospital. So they consider to treat medically before getting into the surgery. So most of the moderate cases are treated by local measures, but not with Botox. Botox we are not using at the hospital. But with other measures, moderate patients are going fine, but not with Botox. I cannot comment on that.
Okay. Do any of the panelists have such experience and would like to comment?
Yes, Dr. Mohammed, I'm Aminim Shams معك.
Okay.
I think, as Juan said, the only using the botulinum toxin is the dermatologist, and so I think we need to concentrate on the thoracoscopic sympathectomy, as I said.
Actually, we have some experience with this topic. We did a research with the some dermatological colleagues. The research was about a comparative study between thoracoscopic sympathectomy and the botulinum toxin, and it ends by the botulinum toxin is effective in axillary hyperhidrosis and not in palmar, but it need to re-inject every 3 or 6 months. So we'll shift completely to thoracoscopic sympathectomy.
So it's very difficult to continue by this method.
Yes.
Dr. Mohammed, yes.
Upper dorsal sympathectomy is the best treatment for primary palmar hyperhidrosis. Do you agree, Dr. Fabio?
I agree. I think I have not direct experience, for example, with botulinum toxin, but dermatologist referred to me a patient that was treated with botulinum toxin. We have to remember also that is painful. It's not a procedure, it's painful. So it's not easy to repeat every 3 months. They told 6 months, but honestly is 3 months, about 3 months to have a good stable results. So it's not effective. I think that is very effective. As I told you, I agree completely with the sympathectomy, dorsal sympathectomy.
Okay, thank you. Now I move the moderation to my colleague Mabrouk. Please, Mabrouk.
Thank you, Dr. Muhammad. Fabio, I will ask you about what is the main advantage of thoracoscopic sympathectomy for treatment of primary palmar hyperhidrosis? Fabio.
The main advantage, we must pay attention very well to the correct indication of the treatment. Is a treatment that must be indicated only in point 3 and 4 of the grade of hyperhidrosis, because we can have a variability of compensatory hyperhidrosis that is really the main problem after sympathectomy. We started for the first procedure with G2 sympathectomy and down, and we found that it was very effective for the hyperhidrosis of the axilla, of the hands. But as I told you, there was in some cases that we had a compensatory heel hyperhidrosis. So the advantage at now of the only selective sympathectomy at the level of G4, the great advantage is that it's very fast, is effective, practically without side effect. And so I think that for the boy, for the adolescent that can check your hands just after the operation is very enthusiastic, is very good. It's very good.
Thank you, Dr. Fabio. Same question for Dr. Shahata. Dr. Sharif.
Actually, Dr. Mabrouk, I'm in agreement to what is said by Dr. Fabio that the primary palmar hyperhidrosis thoracoscopic sympathectomy is the gold standard, but we have to put in mind the selection criteria and the exact level. You have to be at T3 or T4, because many of the cases, if you go above, like in T2 or between T2 and T3, you will have many problems like the recurrence or compensatory hyperhidrosis, and in some cases there is some dryness. So we have to wait. Sometimes if you have to treat, you should tailor your treatment per your patient. If you have a patient with palmar hyperhidrosis and axillary of the ipsilateral side, you have to think about rather than a case of just primary palmar hyperhidrosis, where you can sure by T4 or T3 is enough for him, but not going up, and keep usually that in mind. Some dryness will happen, especially after the compensatory hyperhidrosis in some of your patients.
Thank you, Dr. Sharif. What about the main criteria for surgical patient selection? This question for Dr. Juan.
Yes, as Fabio said very clearly, you have to divide the patients into two groups. The severe problem that allows or produce the patients to have in trouble all day long, so they cannot barely live with the problem. Those are the patients that are really benefit. They are going to be benefited with the surgery. And the patient that has from time to time troubles and is not disturbing all day, you can wait, because sometimes it is related with stressful lives, and many teenagers are under pressure at the school or at family. You have to have even psychologist consult before going to surgery if you think that there is some stressful thing that is responsible of the stress and the sweating. Once this is ruled out or confirmed, you can proceed accordingly. So I think it's very important to distinguish the patient that is sweating and has troubles with the lifetime work or things that he's doing or she's doing. I think this is the one that is the best candidate to do it.
Thank you, Juan. The same question to Dr. Ahmed Durgham. What's your opinion about the criteria of surgical patient selection, Dr. Ahmed? Dr. Ahmed Durgham.
Ahmed, are you here?
Dr. Ahmed.
Okay, Mabruk.
We will
Can you pass it to Dr. Menem Shams?
Dr. Menem Shams, yes.
Thank you, Dr. Mabruk. I think the main criteria for selection of the patient is number one, the age of the patient. And I see many questions asking about the age of the patient for interference by thoracoscopic sympathectomy. So the main criteria, number one, is the age of the patient. And the sweating is more and more affecting the patient, the child functions. And so you must be aware by this point. So number one is the degree of the sweating. Number two, must be primary hyperhidrosis. Must be exclude the secondary cause for the hyperhidrosis. And the number four is the when affecting the age of the patient more than 15 years or more than the 18 years, may be affecting the patient work. So you must be interfere in this point. Mabruk.
Thank you, Dr. Menem. Mabruk, are you here? Okay. The next question, we have many...
Unmute Dr. Mabruk. Dr. Mabruk, your phone muted.
Yes. Thank you.
As
regarding the position of thoracoscopic sympathectomy, there is many positions, anterior, posterior, lateral approach. Which approach and position do you prefer, Dr. Magid Ismail?
Yes, we prefer usually in our section the supine position, because it allows us to tackle both sides in the same position without interruption of the anesthesia and the anesthetic. But the lateral position with the upward elevation of the upper limb is a good alternative position. It gives us better ergonomics to deal with the intrathoracic structures. However, also the posterior position could be applied, and the patient lies on his face, and you go from posterior. All this is accepted, but I prefer, if you have a good anesthesia, using the double lumen tube and give you a very nice field inside the thorax. Actually, it is the most important point to select the position of your patient. As regard our section, actually, we have used the fiber optic technique for introduction of the tube, where we can deflate the side properly and we can see everything in a nice way. in single position without allowing the anesthesia to be disrupted by changing the position during surgery from right to left.
Dr. Fabio, I want to ask to also which approach and position do you prefer?
Okay, I tried different position. Obviously, the faster position could be the supine position, as I agree with Professor Magid, because it's easy to change sides without changing the position of the patient. That we have not to forget that are with a great heavy patient, so we have to move completely. We spare time sometimes more to move the patient than to do the procedure. But we have to take in account two points. First of all, that is advisable to me to make, as Professor Magdi told, to have a selective intubation, because with selective intubation, you don't need the CO2. And so you can work with a few instruments, probably a couple of instruments. When you have the supine position, the problem is that sometimes you have the lung, even if it's completely collapsed, you have the lung just in front of you, sometimes, not always. And so you need another forceps to move. In lateral position, this doesn't happen. In lateral, semi-prone position is the best, because the lung collapsed, fall down, like an esophageal atresia, you know, and it's very, very easy direct to access directly to the chain, never to the chain. And now we use the lateral position. Why? Because we can use less trocar, less instrument, and we see clearly and directly the chain. But I think that depends also.
Dr. Juan, do you prefer to use a double lumen tube, or you use simple tube anesthesia for thoracoscopic sympathectomy?
Yes, at the beginning, we were using only CO2 pneumothorax, controlled pneumothorax. And we also are using the supine position with a semi-sitting and both arms above the head. Okay. But now we do always double lumen endotracheal tube, always using when we are doing, especially because these are old patients and it's very easy to use it. And it's very, very good to deflate the lung because you have very good access to the T3, but T4 and T5 is very difficult to get there. So deflating the lung, it's much more easier and helps a lot. So I recommend it.
Thank you, Dr. Juan. Dr. Sharif Shahada, same question, do you prefer use double lumen endotracheal tube or no?
Actually, Dr. Mabruk, I am using the simple tube, not the double lumen tube. And I think most of the Egyptian center are using simple one. I use the supine position with slight tilt, just 30 degrees, because simply I didn't recommend, I didn't do bilateral cases in the same time, usually one by one. You hear me?
Yeah.
Okay.
Yes,
Yeah.
help.
Very
So
clear.
the simple tube, and it is not available in many of the double lumen, many of the centers.
Thank you, Dr. Sharif. Mabruk.
As regards trocar, there is many school as the number of the size and the size of trocar. I want to ask Dr. Dr. Fabio, about the number, size, and size of the trocar which you use in the thoracoscopic sympathectomy. Fabio, Dr. Fabio.
As I show you in the last topics, honestly I use three trocar, but not a trocar, 3-axis. One trocar 5M for the camera because it's very clear, very good signal, and one or better 2 forceps without trocar, 3M forceps inserted directly in the thorax because are almost scarless, and with the 2 trocars you can work very well. We can control very well everything. If you have a little bleeding, you can clean, you can control, and you can see very well the gag. You can also use, I have a very nice optical device that I use for newborn that was, I show you, it was 5M optical device with operative channel of 3M. The problem is that you can work also with 1 trocar if you want, so in this way you can see nothing. But the problem is that mainly the vision is not so clear, and if there is a little bleeding, you can distinguish very well. You can't distinguish very well the accessory branches of the nerves. So usually it's very fast, it's very safe to me to use 3 trocar, 1 operative trocar of 5M, and two access, not trocar of 3M, to make the cautery. I recommend you, I don't know, it will be in the next slides, to use more bipolar coagulation or something else.
Okay. Thank you, Dr. Fabio.
Yeah, same question.
Mabruk, Dr. Ahmed Duram is here now.
Yes, thank you, Dr. Muhammad. Thank you. Same question for Dr. Shams. What about the number, size, and set of trocar which you use in thoracoscopic sympathectomy?
I think that Fabio said our experience is only 2 trocars in the mid-axillary, 5th mid-axillary space, 5 trocar for the camera, and at the 3rd anterior axillary line, we can use the 3 trocars, and also we can use sympathectomy or sympathotomy. But when you are using clipping, which was our experience in this technique, we use 5, only 2 trocars, 5 millimeter for the camera and the 5 millimeter for the clip applier. So we can use only 2 trocars, number 5, or you can use only 1/5 meter, and the other one for the endoscopic sotomy or
Thank you. Thank you, Dr. Shams. I want to ask about how to identify the sympathetic chain. This question for Fabio. Dr. Fabio?
Okay, yes, I hear you. Okay, I can hear you. I can easily identify the sympathetic chain as Juan told. When you have to start the procedure, you have to go to the origin of the ribs. You can see clearly the chain by the pleura. You can see clearly the chain, and you have to start just on the rib to open the pleura. Then, when you go under the second rib, you go directly to the second ganglion. when you have to go obviously to the third ribs, under the third ribs, you can clearly see the third one and so on. It's, to me, as I told you before, is I like to have a very clean field. So this is the reason why, to see very, very well the nerve, I sometimes use 3 trocar and of 3 ends that are scarless, and they can lead you towards very well, seeing very well where you have to go.
Okay. Thank you, Fabio.
Can I recommend something?
Okay.
If you don't see very well the sympathetic chain, you can increase the pressure up to 8, and if you apply more pressure, the nerve is easily seen. So if you are using 4 millimeters of mercury, you sometimes it's low, and you can miss it. So if you increase up to 6 or 8, the nerve is seen much more better.
Okay.
Yes.
Thank you, Juan.
Professor Dr. Magid, there is any landmark for to identify the sympathetic chain intrathoracic?
Yes. The problem, if you didn't see the sympathetic chain, especially in obese children or obese patients, actually you can roll the hook over the lower border of the neck of the rib. You can identify the sympathetic chain very easily, and you can roll it. In addition to the tick and the trick of Dr. Juan, that increased pressure give us a good view of the chain. But if you didn't see go in a good way, you can feel it by rolling from medial to lateral over the neck of the rib. This is the typical anatomical side. So that if you didn't see, you can feel. What this is my message.
Okay. Thank you, Dr. Magid.
In a bilateral cases, which side to do first, Dr. Juan?
Well, I don't have any preference, but as I just start with the left and then to the right, but I think I don't know why, but I think it doesn't matter.
Can I speak? Can I say I'm scaramantic? I start always from the right side and then I go to the left.
It has been. Yes, go ahead, please.
Dr. Sama?
Yeah. It has been mentioned in some literature that you start with the dominant hand first, because if you have any trouble, you cannot finish, then you have done the most important hand. If you have time, you go ahead and do the other hand.
More complaining hand.
Yeah, or more symptomatic hand.
Yes.
For myself, the right dominant hand is the first selection for me. Because I feel it is more easier than the left. Why? I don't know. But this is my feeling. Start by the right. This is good.
Dr. Mabruk, can I have a comment, please?
Yes.
Yes. Actually, as mentioned by Dr. Samah, I usually in bilateral cases, as I mentioned before, I never do the 2 sides in the same session. Start by the dominant hand, and please keep yourself with this.
Why?
I can't hear.
Dr. Sharif?
Frozen.
Can you repeat again, Sharif?
He has a connection problem. Maybe he's trying to come back.
Yes.
So we go ahead until.
That's the best if you have 3 of the trochers.
Okay.
Can you repeat, Dr. Sharif, because you were muted?
Okay. First, I said I didn't do bilateral cases in the same session.
Yes.
I start by the dominant hand, and between the 2 sessions, usually around 3 months, because you can see hyperhidrosis or dryness, but all the time do in a good view using 3 trochers, as mentioned by Fabio and Juan. because when you need to feel in obese children, even the ganglia, you need to have the hook and a Maryland to roll in between before you opening the pleura.
Right.
And if you have small bleeding from one of the veins behind the pleura, at that time, when you are using just two instruments, one for the optics and one hook, you realize that you need the third instrument for the safety and the clear vision.
Can I add her, Dr. Abdulaziz?
Okay, go ahead.
As I said, Dr. Sharif, our experience from all our history, I will do bilateral, the same setting, and so no need for interval of 3 months. The number one. Number two, we are using only two trookers, one for the camera and the other one for the Maryland or for the hook, so we can cut or by the sympathectomy, or even by clipping, or even by sympathectomy, by cutting or excision of a segment of the sympathetic chain. Only one trooker.
Thank you, Dr. Menem. Okay.
Thank you, Muhammad. Dr. Muhammad will continue as the moderator for
Thank you, Dr. Mabrouk.
Thank you.
The chain section method include, as Dr. Juan and Dr. Fabio mentioned, sympathectomy, which is a resection, and sympathotomy, which is just a transection, and the clipping. The multiplicity of the technique indicates that there is no ideal technique. The question is, which method do you prefer? For Dr. Sharif Shahata.
Actually, I do sympathectomy and I remove almost something like 3 to 4 millimeters of the chain, because this is the only way that you are sure you're removing the part, not just doing by the cautery. Okay.
What about compensatory sweating, Dr. Sharif?
It occurs whatever you are doing, but usually it is the incidence is not too much, because you are using a small part, not in one level, and cut 2 to 3 millimeters only to remove the part. And don't use the cautery, the monopolar cautery.
Yes. Do you add cauterization of the rib laterally?
No. If I use bipolar.
Yeah, but you don't.
Sometimes, but it is not the standard. Sometimes if there is some bleeding, but usually I didn't add for the other afferent neurons. No.
Okay. Thank you, Dr. Sharif.
Our study now, MD thesis, we are using all the patient to do cauterization of the rib, few or centimeter, only to touch.
Yes.
No. So, we nerve of liturgy must be cauterized in this.
Okay. Now I move the same question to Dr. Juan.
Yes, I tried to use clipping in some patients, and I had to come back because it was incomplete results. And then I only apply electrocautery on the clip, and the result was perfect. But most of the times what I'm doing usually is sympathectomy, only one level, but removing among half centimeter or so.
Although I agree with Dr. Sharif Shahata that excision is more safe, most of the literature prefer to do just transection. I don't know why. Maybe it is easier and take a shorter time. What is in your opinion, Dr. Fabio?
I prefer in these cases, I prefer to be effective and to make only one operation. So I prefer to be very selective, and so I go usually, for example, for hands, as I told you, on G4 with the sympathectomy, complete sympathectomy. I look at the literature also for the clips, because there was very interesting the application of the clips, but I saw that is quite difficult to make reversible the effect of sympathectomy because you have to do it in about 14 days after the operation. So after the 14 days, in literature, is the consensus is that is quite irreversible. And so, as I told you, I prefer to make a very accurate selection of the patient, the symptoms, and to go the much more definitive possible to resolve the problem. So I do sympathectomy. Sympathectomy that is easy and faster.
So you excise the segment, yes.
Mhm.
Dr. Muhammad, just can I make small comments? Because most of the literature coming from the cardiothoracic surgeon, the thoracic surgeons.
Yes.
So take care because they have usually older age, and from us as in pediatric surgery, a little bit different. So when you are revising the literature, be careful with that because
Actually, we have now MDCC's comparative study between excision and transection. And we found, as you said, in the literature in children, some prefer to do excision. And we will go through this study and we'll tell you the results. Okay?
Thank you.
definitely.
Okay. The question now for Dr. Ahmed Ram, which type of energy device do you use to transect the chain if you are going to transect or to excise? Ahmed Ram? Dr. Ahmed, are you here? Dr. Ahmed? Okay, can I pass this question to Abdelmanem Shams?
The question again, Abdelaziz.
Which type of energy devices do you use to transect?
Our experience only by monopolar diathermy. Our patients by more than 200 patients with unipolar.
You mean hook or other?
Hook by hook method, or even maybe using the Merlin to elevate the chain and then we cut by the seam.
But you don't use
or
harmonic.
even by needlescopic. By needlescopic, we can dissect, and the sympathectomy will be done in the same maneuver.
Okay, the same question to Dr. Juan.
Yes, I also use the hook. I don't use bipolar, and I never had any problem because if you are very careful with the hook, you only coagulate the segment.
Okay.
But Juan, you never go to T2 ganglia.
Yes.
No.
Yeah.
Because
then you are so close, and the monopolar might transmit higher up. So.
Yeah.
Okay. The next question is about clipping. So is the clipping method a reversible procedure? And I'll pass this question to Professor Sharif Shahata.
I didn't have much experience in the clipping, but from literature, it is reversible in the first 2 weeks. But if you wait for more than, the injury will be permanent.
Yes.
This is the point. But you can remove the clip, or if it is incomplete, you can complete by sympathectomy.
Okay, yeah, you can remove it within 2 weeks, you mean?
Within 2 weeks, after that, no.
Yeah. What is your opinion, Dr. Fabio?
I usually don't use the clip, as I told you before. It was interesting, but I don't use it, and so I can give you my experience.
Okay, thank you, Dr. Abmenem. I know you have experience in this method. Can you tell us? Dr. Abmenem Shams?
We are using the clipping in MD theories, and I think now it's finished now. The MD is ready now. So
yes. The question is, do you need some time?
And the clipping, I think in our cases, 2 cases was, you hear me?
Yes, I hear you.
Oh, yes.
Yes, Dr. Aminem, I hear you.
Repeat
Yes,
again,
yes.
Abdullah.
Yes, we are using the clipping in MD theories, and we are finished now the immediate theories, and will our experience in this clipping, I think, need more studies, more and more studies, and no problems, technical problems with the clipping and the recurrence, or when we are needing to repeat in only 2 cases we are needing for the remove the clips.
I just ask about the complication of the procedure. If you need to remove the clips, is it
reversibility?
Yes.
Yes, is it, we need in 2 cases, Abdulaziz, we are removing the clips again.
Okay, and this applicable.
Recently improved.
And
Okay.
after 1 month, I
After
think
1 month.
in the literature 2 weeks. Yes, and I know in all literature after
2 weeks.
2 weeks. But
Yes.
I think in this study, as I said, Dr. Sharif Shahada was in adult in thoracic surgery. I think it is more different in pediatric age groups.
Okay, thank you.
My worry, Dr. Muhammad, my worry about the clipping is that if you look at, again, at the literature, you see that sympathotomy or division alone is attended with some instance of recurrence because of regeneration. So if you are not interrupting the sympathetic trunk and you're applying only a clip, there is a possibility of recurrence. And you have, Dr. Abmenam, you mentioned 2 cases of your cases. So this is a worry.
Okay. I think I agree with you, Dr. Sameh. Clipping is just blocking the chain, and biologic, if the transaction has recurrence, what about the clipping? So we will see the result of Dr. Shams. Okay. Debates continue not only about the best technique, but also about the chain section level. So the question is, what level of the chain do you recommend to be sectioned? The question to Professor Juan.
Yeah, definitely. For hand is T3 and for axilla is T4. But if you do T3, also axilla is affected, but not too much. But also people are doing T4, and palmar hyperhidrosis is also getting dry. So it's my recommendation is T3 for palmar and T4 for axilla.
Okay, and you use T3, not R3. The difference
is actually is ganglia number 3 for palmar and ganglia number 4 for axilla. So it's under the rib, 3rd rib, and under the 4th rib.
Okay, and Dr. Sharif, the same question?
Exactly like Juan said, T3 for the hyperhidrosis, the palmar, and T4 for the axilla. And some cases can improve if you do for both, and you should tailor individual for each patient. If your patient have both, you think about if you're getting 2 levels or 1 level. If your patient only palmar hydrosis, T3.
Okay, thank you, Sharif. Now I pass the mic to my Professor Dr. Sameh Shahata to continue the moderation. Please, Dr. Sameh.
Thank you so much, Dr. Muhammad, for excellent preparation and moderation. And I thank the 3 speakers for excellent. Actually, they left nothing for the panel questions. They clarified everything, but still we can find a way to concentrate or focus on some topics for emphasis. So, Dr. Maged, you have a huge series.
Yes.
And of course, in some cases, you met with some technical difficulties in exposure. So what are the causes and how could you manage them?
Yes. At the start, we didn't use the double human tube for anesthesia. And so that complete deflation of the lung was a problem. What we have to do is we have used the fiber optic endoscope to introduce the single human endotracheal tube to the proper lung and the proper side of the lung. This solves many problems for us as regard the deflation of the other one. Also the insufflation. We have used instead insufflation between 4 and 6 in order to deflate the lung in a good way. According to the age, we can increase to 8 if we have an adolescent. And in some cases, if the sympathetic chain does not appear, we can increase this is as regard the visualization of the sympathetic chain.
Very good advice.
Some difficulties may be faced in obese patients. I go to my feeling, as I have said, you can roll the sympathetic chain over its proper anatomical side. This point should be put in mind if you didn't see the chain. Feel, you can feel. And this way,
go ahead.
And this way you can identify the sympathetic chain. Sometimes we may have some adhesions. I don't know why. In some cases, and the adhesive license should be applied in those cases. Blind cautery of the pleura over the 1 centimeter lateral to the second and third rib. This may cut the communicating rami and may cut may prevent recurrence of the problem.
Thank you so much, Dr. Magid. They say that one of the disadvantages of minimally invasive surgery is the absence of tactile sensation. You cannot feel the tissue, but you are expert enough to feel with your instrument. You feel
Once you roll
you feel it, yes.
You feel it and polish in front of the pure instrument.
Yeah, it is the only perpendicular structure, white ribbon that goes perpendicular to the rib. Very good. And of course, you expect that if there is a previous chest surgery, whether open or laparoscopic or thoracoscopic, you find some adhesions. You are asking about what are the reasons for adhesions.
Yes, sometimes without any surgical interference,
you find
maybe due to repeated chest infection, pneumonias, and so on, you may find some adhesion that should be sacrificed for surgery to allow you proper exposure of the sympathetic chain.
Very good. Next question. Well, this is Kunt's nerve is very important because it's present in some good number of patients, up to 70%, and it can result in some failure. If we agree that sometimes we cannot see the sympathetic trunk itself and we need to do some maneuver, then definitely this small nerve of Kunt's cannot be seen. So I'd like to ask Fabio what to do to avoid missing the nerve of Kunt's.
Well, I want to say that usually, as I told you in the last procedure, I never go directly to the G2 because we know that Kunt's nerve is above all in G2. The trick is very simple trick. You have to cut the chain, to take the chain to pull towards the high part of the rib. You find the tiny nerve that you can clearly identify. You must pay attention, as someone of us told, to, not to pull too much, because you risk to create a lesion to the stellatus nerve ganglion, and so we can have a temporary closed Bernard Horden, and also not to use. Recommend you monopolar energy because it can spread to the ganglion, and so you can spare the relapse, but you can create some damage to the annulus lenatum. So this is my opinion.
Yes, Sana. Yes, Sana. Would you
Yes.
believe? Yeah.
Yes.
Yeah. My opinion is to start from lower down to this up the second rep. This procedure allow you to see the whole communicating branches to the main sympathetic chain until you reach the second ganglia. You can sacrifice by scissor and not by cautery, and then take it to the outside. Once you take the sympathetic chain from lower down upward, you will clarify all the communicating branches, even the Kuntis nerve.
All right, Dr. Knight, but it has been
Dr.
mentioned.
Sameh, can I
Yes.
add here?
Yes, please go ahead.
Shams with you.
Yes.
In cauterization of the rib, I think this can prevent the recurrence in 2% of cases, as you said. And the nerve of Kunt, I think, would be cauterized in this maneuver.
Yes, the problem is that this is a tiny nerve that in many cases could be missed, whatever, you cannot identify it. So I think it has been described in many of your video demonstration that you go on the rib for about 4 to 5 centimeters laterally with division with the hook. You divide the pleura, and then you are sure that, or other people may cauterize over the rib. The same reason to avoid missing the Kunt's nerve. This needs to go 5 centimeters, 4 to 5 lateral to the sympathetic chain. Now we go.
Medial. Sometimes the communicating fibers may be medial and not lateral.
Well, these are the gray and the white Remi communicants.
The main point is to remove the ganglia. This is the site for communication of the nerves. Once you remove the ganglia, you cut all the communicating branches, even the constant.
Actually, Dr. Sameh, may I comment, small comment for this point? You need to have a very good incision of the pleura, as seen in the video of Fabio and the Juan. Very good incision from the lower margin of the stellate ganglia. You don't just incise the pleura down for 4 or 5 centimeters, and at level of T3, you can see 1.5 up and 1.5 centimeter down. And if you just pass behind and look to skeletonize, you can see with good optics, you can see the small branch in many of the cases coming from down, going up to the stellate ganglia. To keep in mind.
Okay,
Right.
Can I comment?
Yes, please, go ahead.
There is a landmark written in the literature, which is the subpleural intercostal vein. They claim that the nerve is passing parallel to this vein. So as Dr. Sharif Shahata said, if I open the pleura wide, I can see this vein, and so I can notice if there is nerve.
But in some cases, we can see the post-operative back pain when you are you much cauterize the rib. If you cauterize the rib much and much, we can see back pain in some patients.
Okay.
Yeah, you don't go to the periosteum. I mean, you're only pleura and subpleura and not into the periosteum. Of course, this can lead to post-operative pain. The big problem actually of sympathectomy is a post-operative compensatory sweating, which in some reports will go from 10% to 80% or even more. So this is our big problem. We need to tailor our results to see how the best way to avoid it. I know this has been mentioned in your all your talks, but I go to Juan and ask him, what is the best way to avoid? Is it acceptable at the end of the day, and how to avoid it?
Yeah, what I think is not acceptable to have that result because sometimes the compensatory sweating is more distressing than the hyperhidrosis. So I think it's better to focus only in one ganglia ablation, and after that, if you need to come back because you have a recurrence or you have an incomplete result, it's better than to have a compensatory sweating. So if we try only to do one segment, I think it's enough to have an acceptable result. Probably it's not perfect because there is, if you want to have a very, very dry hand, then you have to apply creams, ointment after the operation because it's very dry. And then you have compensatory sweating. So I think it's better not to have a complete dry hand, just a dry hand, but an acceptable dry hand. And then if you do that, you don't have compensatory sweating. So I think we must focus on one segment only.
This is a very good advice, Juan. Sometimes sessions will go very aggressive to avoid recurrence, but then you get worse results or complication. So it's very wise. One level, this is clear. And if you need in a small number of patients to come back again and take another level, that's success. Perfect. And the clear, wise result. All right, I pass it back to you, Dr. Abdulaziz, the mic to complete the question.
Okay, thank you, Dr. Samah. Dr. Tamer Ashraf, are you here? Dr. Tamer? Okay, so I will continue.
Yes, Dr. Muhammad, please continue.
Okay, thank you. The next question is, can we predict compensatory sweating following thoracoscopic sympathectomy? The question for Dr. Fabio.
Yes. Is the question very linked to the previous question?
Yes.
Because in the first patient, I prefer to be very definitive. And so I do complete sympathectomy from G2, G3, depends on what you want. But in the last patient, but in that cases, I had a variable percentage of compensatory sweating that is not acceptable because it became a very great problem sometimes. So we have to add sometimes drugs like anticholinergic drugs to reduce this kind of problem. So in the last period, in the last patient, I'm completely agree, as I told you just before, also with Juan, I go directly to the ganglion that I need to afferent to, for example, to the hand, to the axilla. And this is a very good way to prevent the high incidence of the compensatory sweating.
Actually, my question is, before we are going to do thoracoscopic sympathectomy, can we predict in which patient this complication might happen?
Just before is very difficult to me. No, I don't know because it's
cannot detect. Yeah.
Yes.
Okay.
It's described in literature to make a blockage of the sympathetic chain by local anesthetics. But I think it's not necessary because it's difficult to advance the compensatory sweating problem.
Okay, thank you. The next question is to Dr. Sharif Shahata. Do children tolerate thoracoscopic sympathectomy better than adults?
Actually, I did have much experience in adults, but I do sympathectomy from 5 years on.
Yes.
The youngest age I have done for hair sympathectomy, thoracoscopic, is 5 years old girl, but I think most of them with one level is doing fine. And we have to follow up because some cases came to me after 7 years complaining from some of the compensatory, which appears very delayed. They stay for 1 or 2 years, okay, start to complain after 7 years.
Yes, but as you see, there's a lot of researches in the literature as this how young is too young, and they claim that the earlier you do thoracoscopic sympathectomy, the best result you gain. So What is your opinion?
We don't have a longitudinal study. We need to make a good database, making a longitudinal study for all the cases and see, because many of the cases, even compensatory hyperhidrosis, when occurs, improved with time. If you are sure that you are doing it is in a good, some of the cases improve with time.
Yes.
So the only way is to do a good longitudinal study.
Okay, thank you, Dr. Sharif. The question for Dr. Fabio, is there any relation between quality of life and the level of sympathectomy in primary palmar hyperhidrosis?
The quality of life, in my experience, improve dramatically. And when you do the selected, very selected sympathectomy. And on the other hand, I found, as I told you before, not a good quality of life when you want to be very aggressive and very without relapse. So in the last cases, I prefer absolutely to be very selective and to reduce the side effect as my main aim.
Okay, thank you, Dr. Fabio. The incidence of recurrence may be up to 4% with long-term follow-up. The question for Dr. Juan, do you have any precautions to avoid this recurrence?
Well, as I mentioned before, I had recurrence when I was applying clips. So I stopped doing applying clips because I think we had more than 4% of recurrence, was about 20% of recurrence. And this is unacceptable. So I think the precautions is to identify the kind of patient you have. If you have a mainly palmar hyperhidrosis, it's easy to correct, so you don't need to have take any precautions. But if you have palmar and axillary, it's a difficult one, and probably if you do only one level, it's going to have some kind of recurrence or incomplete resolution of the problem. But as I mentioned, I prefer to be very careful and to come back because this is a straightforward operation, and I think it's better to come twice than to overtreat.
So your message is to just work on one level in palmar and the 2 level on palmo axillary.
Yes, both.
Okay, thank you, Dr. Juan. The question to Dr. Sharif Hatta, do you have any experience with reoperation with recurrent primary palmar hyperhidrosis?
It is feasible. You can do it thoracoscopically. I have only one case that have been done before thoracoscopically, and we do for the recurrent after 1 year redo thoracoscopic sympathectomy, but we took T3 and T4.
Is there any difficulties during this procedure?
Usually there is some adhesions. You have to be very careful, but because all the time I use the standard 3 trocars, so I used to cut and take it very carefully. So, but there is some adhesion from the first one.
You already
can I add here, Dr. Abdelaziz?
Okay, go Shams.
We have 2 patients with recurrent cases. One for after clipping of the sympathetic chain, and the other one was compensatory hyperhidrosis. We are doing the procedure again for this first case was clipping, and redo by sympathectomy and not by clipping. The other one, what was compensatory hyperhidrosis, we are doing sympathectomy again, and the patient improved in the 2 cases. And there is adhesions, pulmonary adhesions in the 2 cases. When you are doing the redo, and by only 1 trocar for the camera and 1 trocar for the instrument, we can cut all these adhesions without need for the third trocar.
So you do transection or excision, Dr. Shams?
Sympathotomy on.
Sympathotomy and.
Okay,
Yes.
thank you, Dr. Shams. Although chylothorax following thoracoscopic sympathectomy is a rare complication, it could happen. This question is especially for Dr. Juan. Do you have experience in managing this complication? I know you have this experience, and you.
No, well, I have experience with chylothorax, especially in neonates
Yes.
after cardiac surgery and congenital ones. But I didn't see any complication of chylothorax after sympathectomy. I think it's quite rare complication, and if you are having that, is because you didn't do a proper operation. So my advice, even anything the cause, if you have a chylothorax after sympathectomy, my advice is to come back and to try to see the leaking, because it has to be close to the place you were working on. So you can come back by thoracoscopy there. If you don't see the leaking, what we are doing is applying starch to do pleurodesis to fix the pleura at that level. And the way we are doing, I can show you if you want a video.
Okay. I can stop sharing and you can share your presentation?
Yes.
Okay. Okay, go now.
So if you see here, this is the way we treat chylothorax in neonates. We put in lateral position, we put the camera and one working port in that way. I will try to advance. Can you see it?
Yes.
Yes, yes.
Okay, so I remove all the adhesions with a sponge. This is a 3 millimeters instrument, and on the left, and 5 millimeters put in directly through the thorax. So you have to gain access to all the pleural cavity, and then I apply starch. The simpler way is to have a 50 cc's syringe, and you can see here, this is the starch. This is the visceral pleura and the parietal pleura. And with that, you obtain a complete, it sticks the pleura, both pleuras, and chylothorax stops because it gets isolated in the place what is happening. Okay.
Okay.
This is the experience with several procedures, but I think it's enough for by now. Okay.
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 Thank you, Dr. Juan. Actually, we came to the end of this panel discussion. I would like to thank all my dear panelists for their outstanding discussion. I don't know if we have time to take a few questions from the chat room.
Many thanks, Dr. Mohammed.
Do you agree?
Yes.
Do you agree to take some questions from the chat room? Dr.
Can
Juan?
take 10 minutes.
Okay.
Dr. Mohammed, all points I think covered by most of the speakers. So we actually we have a lot of questions, but most of points covered by all speakers.
Do you have unique questions?
Yes, Dr. Mohammed.
Okay.
Yes,
Dr. Samir, تفضل.
Good night, my colleagues. I am Samir Gouda, professor of pediatric surgery. I collect some questions from the chatting room. to Dr. Fabio. Dr. Fabio, you
Yes,
hear me?
yes, yes, I can hear.
Is the age of the patient affect the plan of management and outcome? The age of the patient affect the plan of management and outcome?
Yes.
Sorry, patient. Sorry, can you repeat what is the outcome for the patient?
Age of the patient.
The age. Okay. The age usually, I have not experienced with a patient less than 7 years old. I've experienced above all the range is about 12 years, 11 years old patient that treat successfully. As told before, Shiata told before, I think that the best results and are in the younger patient because are effective, and so this is my experience.
Second question, Mr. Fabio. Is the body mass index affect the plan of management and the post-operative outcome? The body mass index.
The body.
Yes.
The body.
Is the body mass index affect the plan of management and the post-operative outcome? The body mass index.
Body mass. Okay, the body mass. Okay, understand. Okay, the body. I don't calculate the body mass. I am agreed with Professor Magdid. It's much difficult in the patient to treat this problem because the fat sometimes can hide the nerve and a little bit difficult to find. So it's important to have not high body mass index. Okay.
Last question to Dr. Fabio. Are you facing a patient with the absent sympathetic chain during your work?
I have had, sorry because my audio is terrible. What sympathetic chain?
Are you facing a patient with absent sympathetic chain during your work?
Absent?
Absence.
No.
Absent.
I saw every time sympathetic chain. And I have to make also a comment about the chylothorax because in the previous question you asked if someone had the chylothorax. I never had the chylothorax secondary to this procedure because the problem sometimes is when you can't find very well the chain, you search for too much medially, and so you can miss the nerve with the thoracic duct. This is the problem that you can have during the procedure, and so you can create damage. And I found a patient that come to me that has a procedure with a sympathectomy. It's a very important question, this, and he had already the hand not the trap west, and he missed.
Listen.
Okay, I can hear. Okay.
The last question to Dr. Fabio. What about the combined technique? Excision of the at one side and clipping at the other side.
Okay.
What's your experience?
Could be. My experience is no. I have no experience in clipping one side and the other side the cutting. And I usually am very selective, as I told you, and I do bilateral sides of the patient, not clipping, because I have had a patient that came from another colleague, very expert, that had a relapse after simply clipping. So I usually decided to do the sympathectomy, and it's effective without side effect, and so it's good.
Yeah. Thank you.
Thank you, Dr. Fabio. Now we can shift to Dr. Abdelmenem Shams. Dr. Abdelmenem, can you explain the cause of bradycardia or death that may occur during thoracoscopic sympathectomy?
I think the main cause for this bradycardia was, in our cases, was not by the technique of the sympathetic chain, but by the increasing the pressure of the CO2 intrathoracic. And all our cases, we use only 5 millimeter mercury for the CO2, not increasing more than 5. So we can not see the bradycardia affecting this patient.
The last question to Dr. Abdelmenem. What is the most common intraoperative complications that may occur with you, and how to avoid?
Only our cases, the intraoperative complication was some cases we see bleeding, and we can cauterize this bleeding very easy without any problem. So not to care, not touch the big vessels, and we can also use unipolar diathermy to control this bleeding intraoperative.
Is there massive intraoperative bleeding occurred with you? Massive intraoperative bleeding?
No, we are not seeing this problem in our cases here.
Do you have an experience of this occurred? What do you do?
I think it must be, I'm not facing this problem, but if we are facing, I think it must be open thoracotomy and deal with the big vessel problem.
Call for cardiothoracic surgeon.
Yes, or call for surgery. But you must open first and then call for that thoracic surgeon. Yes.
Okay.
Thank you, Dr. Abdelmenem. The mic will be shifted to my dear colleague, Professor Ahmed Abdelghaffar. Dr. Ahmed?
Oh, hello.
Dr. Ahmed Abdelghaffar?
Are you here, to Ahmed?
Yes, I am here.
Okay, you have a question?
Where are you?
I'm fine. Regarding, yes, my question to Dr. Juan regarding the recurrence after thoracoscopic sympathectomy. The question is when to re-interfere. Are there is a mandatory period for waiting before the second operation? And you think you will need an additional preoperative investigation, or you need to change your assistant, or you need to change your telescope, or what you think about this regarding the re-operation, the timing, and if there is any additional investigation you required, or if you need to change any of the equipment or the segment before you re-enter the second surgery?
Yeah, for the second surgery, you have to wait at least 3 months because you have to wait until a lesion is completed. So a minimum of 3 months is reasonable before going back. And,
yes.
And the most important thing is to have a good record, the clinical history, to have very well record of the symptoms and to try to identify if you need 1 or 2 levels, if it's palmar and axillary, because most of the times the recurrences is because you have complaint only by the hands, but the patient is not complaining of the axilla that is also involved. So when you do only 1 level for the hand, then you have to come back and do another level for the axilla. So it's very important. This is a very common mistake when you are starting with this, not to do a very good complete medical record. That this is the best thing to avoid recurrences. And when I came back, you can do it with 2 trocars, but I think it's better to go with 3 trocars in order to be sure to push the lung and to see very well the chain, because sometimes you get, you need to have a good view. So I recommend a 5 millimeter lens and 2-3 millimeter trocars to remove the adhesions and to see perfectly the anatomy of the sympathetic chain.
I'd like to ask you about one important point. What do you categorize this operation or this surgery? Is it a minor surgery or moderate or severe? By other meaning, do you need a blood for this patient preoperative? You prepare a blood or not? Number 2, you prepare an ICU. Number 3, Do you call some of your friends of cardiothoracic to be standby if you need to interfere? Do you think about these items, or by other way, all of us known what is known by nightmare about laparoscopy and nightmares? Yes. Do you consider is this a possibility for nightmares for thoracoscopic sympathectomy or not?
No, I think this is a simple operation, but you have to be learned with some experience, and that helps you in the first cases. And then when you control exactly the technique, you don't need to have a blood reserve. You don't have to have an ICU. I think it's a simple operation, and the patient can go home in the same day or the other day.
The last one point, what do you think about the chest tube? Is it for fantastic or is it mandatory?
No.
No. It's not mandatory. It's convenient, but I think you can do it applying 4 or 5 millimeters of pressure, and you don't need to make any selective intubation.
Okay, thank you very much. Thank you.
Thank you to you all.
Thank you. Professor Sharif Shahata, we have one important question. The last one question about the youngest age for this sympathectomy. You did the youngest age.
I told before it was 5 years.
5 years.
Yes.
And this is the youngest. It depends on the level of the complaint. And actually, she is from a family with a positive family history.
Yes.
Her older brother was operated at age of 8, and her uncle was operated at age of 16.
Very nice. What do you think about 5? Why 5 years?
No, this is lower that. I think there is no complaint. There is no much complaint because she start to go to the kindergarten or preschool, so it start to get in the social life. Before that, just playing, not maybe.
We cannot interfere before that age.
There is no recommendation. Very young. I think you have to keep, but it can be done. But theoretically, why you go? Usually, you should go at the last result if you fail with other things, and should be of severe type. And one of the important factors that the exposure to stresses increase the hyperhidrosis. And in the young children, stress is not much.
And hereditary factor.
Yes, the last point is, what are the most serious complications you should tell the parent of the child before surgery?
For any endoscopic surgery, you have to mention possibility of conversion, recurrence, and especially for hyperhidrosis. And as I mentioned before, you should tailor your management plan for the patient. If you have a patient with pulmonary hyperhidrosis plus axillary hyperhidrosis, you have to mention to them it may be dry, because you will get at 2 levels. If you have patient with isolated pulmonary hydrosis, you will mention only for the recurrence or compensatory hyperhidrosis. So you have to tailor accordingly. There's no one big title include everything.
You speak about the reoperation, the incidence of reoperation?
No, usually I just tell the complaint. Afterwards, you tell them, because not every case of compensatory hyperhidrosis will need reoperation. But don't put the reoperation in the first discussion with the parents.
Regarding the plantar hyperhidrosis, what do you speak about with the parent or the family of the child?
Usually we don't do the lower levels for the plantar, and try to make it with different powders with the people from dermatology. Like exactly in some of the cases of recurrence, some of the dermatology with the buttocks have good, if it is not too much, have good response. And instead of you are doing a reoperation, just with the buttocks or botulinum can make some resolution of the current case.
No, can I comment? Can I comment?
Yes.
Can I comment, Ahmed?
Okay.
Yes.
Plantar hyperhidrosis may disappear by just dorsal sympathectomy or sympathotomy, because This reduces the total adrenergic mass all over the body and reducing the circulating adrenaline and noradrenaline. And this, in most of cases, correct the plantar hyperhidrosis spontaneously.
But I think, Dr. Magid, this improvement is temporary. We have research, and I know you're facing such cases. After 1 year, it will recur. Dr. Ahmed Abdelghafar, I think we came to the end of this meeting. I would like to call Dr. Suleiman to close this session. Dr. Suleiman?
So, in a nutshell, as we all listen to our speakers today, the management of primary hyperhidrosis by using sympathetic thoracoscopic sympathectomy has become one of the most common performed procedures in pediatric surgery. The speakers give us state-of-the-art knowledge, and all of the panelists enriched our mind with this great discussion. Thanks to our experts today, it has been obvious that they spared no effort to make the complicated topic piece of cake. I think we all enjoyed the procedures they showed us today, and we all benefited from the expertise and knowledge. I hope you have found new tricks today to manage your patient safely. At the end, on behalf of both Al-Azhar Pediatric Surgery Department and the EPSA, I would like to thank all our speakers and attendees today who really enriched this meeting by their expertise and their knowledge. Thanks to our guests and speakers today. I am extremely honored to host today's webinar with this collection of pediatric surgery leading figures, and I am looking forward to listen to more and more of their fruitful speeches. Now I am giving the mic to Professor Dr. Sharif Shahata to say goodbye to you. Thank you all, and I wish to meet you all soon in a new scientific get-together. Dr. Sharif?
Actually, on behalf of all the Egyptian Pediatric Surgical Association Board, and on behalf of myself, we have to thank all the pediatric surgical team of Al-Azhar, which is one of the pillars of pediatric surgery in Egypt, for this excellent webinar and the efforts by Professor Suleiman, Professor Muhammad Abdulaziz, Professor Magid, Professor Abdelmunaim Shams, Professor Ahmed Durgham, and all of the team, and hope to see you all the time. And still, I have to announce that still the August webinar open for any of the departments in the Egyptian pediatric surgery. Thank you for all, and have a good night.
Thank you, Sharif. Thank you, Dr. Fabio. Thank you, Dr. Juan. We hope we will meet soon in person. See you, inshallah. Thank you all. Thank you.
Thank you.
Thank you.
Thank you all.
Thank you all.
Thank you all, and good night. Good night, everyone.
Good night.
Ashraf.
Good night.